Assalamu alaikum. Our lecture today is about feeding problems that arise during the first year of infant's life. The objective of this lecture is to know the most important feeding problems that the infant may have during the first year of life. In this lecture, we're going to know the underfeeding and overfeeding, their causes, clinical manifestations, and treatment. Also, we're going to discuss regurgitation and vomiting, a loose or diarrheal stool, infantile colic, and lastly, we're going to speak about constipation. Underfeeding is suggested by restlessness and crying, failure to gain weight adequately. It may result from failure to take a sufficient quantity of food even when it is offered to the infant. In these cases, we should consider that there is an abnormality in the frequency of feeding or in the mechanics of feeding. There is abnormalities in the size of the holes in the nipple of the feeding bottle. There is abnormality in the adequacy of the eructation of air, and we have to put possibility of abnormal bonding between mother and the infant. Lastly, we have to exclude systemic disease. Clinical manifestations of undernutrition depend mainly on the severity and duration of the condition. The infant initially will have constipation, abnormality in the sleep, he may get irritable, he may have excessive crying, the weight gain will be slow, and there may be an actual loss of weight. However, with advanced cases, the skin will appear dry, wrinkled, and the subcutaneous tissue will disappear. The infant will have an old man facies and deficiency of vitamins like A, B, C, D, as well as iron protein may be responsible for the characteristics of clinical manifestation. The treatment of underfeeding include increasing nutrient intake, also correct any deficiencies in the vitamins and mineral. We have to instruct the caregiver in the proper technique of feeding. Any underlying systemic disease, child abuse, neglect, or other psychological problem had to be corrected. Specific management of the underlying disorder is very necessary. Overfeeding. As a rule, postprandial discomfort that result from excessive dietary intake, it will limit the amount of food intake by the infant. However, there are some exceptions. If intake is excessive, then the most frequent symptom is regurgitation and vomiting. Diets that are too high in fat, it will delay gastric emptying, so it will cause abdominal distension and discomfort and may cause excessive weight gain. On the other hand, diets that are too high in carbohydrate are likely to cause endofermentation in the intestine, which is result in the abdominal distension, flatulence, and more rapid weight gain than desirable. Vomiting is defined as violent expulsion of gastric and sometimes intestinal content. Vomiting may be caused by obstruction of the GIT. If the obstruction occurs below the second part of the duodenum, the vomitus is usually bile stained. However, with repeated vomiting, even in the absence of the obstruction, duodenal content will be refluxed into the stomach and the emesis may become bile stained center. The causes of vomiting is diverse. It could be of GIT origin, for example, chalasia or achalasia, or if there is an anatomical obstruction like pyloric stenosis, diaphragmatic hernia, and so on. An extra GIT causes may either result from infection like sepsis, pneumonia, otitis media, or it may result from increased intracranial pressure like meningitis and brain tumor. Also, it may result from metabolic disorder like inborn error of metabolism or adrenal insufficiency. And as previously said, in every cases of vomiting, we have to look for the underlying etiology. So our management usually started with a careful history and then a careful physical examination. We have to look for a sign of increased intracranial pressure, neck stiffness, signs of dehydration, and abdominal examination. And according to the result of our physical examination, we may choose to do an endoscope, a contrast radiography, a brain MRI, or metabolic study. The differential diagnosis of vomiting in children is depends mainly on the age of the patients. A common causes in infant is gastroenteritis, gastroesophageal reflux. It may be result from overfeeding or a systemic infection, while a common causes in older children is again gastroenteritis. However, the next we put systemic infection and toxic ingestion. Treatment of the child is depends mainly on hydration of the patient, and then we have to correct the underlying etiology. Normally, the stool of a breastfed infant is softer than that of formula-fed infant. From about the fourth to sixth day of life, the stool of the breastfed infant will go through transitional stage of being loose, greenish to yellow, and it's containing mucus to the typical milk stool. Subsequently, the use of laxatives or the ingestion of certain food by the mother, it may be temporarily responsible for the breastfed infant loose stool. An excessive intake of a breast milk may cause an increase in the frequency and water content of the stool. However, this is an unusual event, so any diarrhea should be considered infectious until proved otherwise. Although the stools of formula-fed infant tend to be firmer than those of a breastfed infant, a loose stool also may result from artificial feeding. Overfeeding may cause loose, frequent stool, especially during the first 2 weeks or so of life. Later on, formula that are too concentrated or they have high in sugar content, especially in lactose, it may result in a loose, frequent stool. Many diarrheal disturbances in formula-fed infants result from contaminant that would not disturb an older child. Mild diarrheal disturbance caused by overfeeding, it will respond quickly to a temporary decrease or cessation of feeding, withholding all solid food as well as one or several feedings and substituting boiled water or a balanced electrolyte solution is usually all that is required. Colic is a symptom complex of paroxysmal abdominal pain. It is thought to be of intestinal origin. Usually, it is occur in an infant less than 3 months of age. The attacks of colics usually begin suddenly. The infant will have a loud, sometimes continuous cry. This paroxysm may last for several hours. During the attack, the infant face will become flushed. There will be a circumoral pallor. The abdomen is usually distended and tense. The legs is extended for a short period, but they are usually drawn up on the abdomen. The feet are cold and the hands are usually clenched. The attack may not terminate until the infant is completely exhausted. Sometimes the passage of feces or flatus appear to relieve the attack. The exact etiology of infantile colic is not apparent. The attacks seems to be associated with hunger or with swallowed air that may be passed into the intestine. Sometimes overfeeding may result in a discomfort and abdominal distension. Some food, especially those with high carbohydrate content, it may result in excessive intestinal fermentation. Crying with intestinal discomfort, it may occur in an infant with intestinal allergy, but colic is not limited to these groups. Colic may appear just like intestinal obstruction or peritoneal infection. The attacks of colic commonly occur in the late afternoon or early evening, which suggests that an event in the household routine may be responsible. Worry, fear, anger, or excitement, which may cause vomiting in older child, it may result in a colic in an infant. However, no single factor consistently accounts for colic, and no treatment consistently provides satisfactory relief. Since the diagnosis of infantile colic is that of exclusion, a careful physical examination is important to eliminate the possibility of intussusception, strangulated hernia, and other causes of abdominal pain. Once the diagnosis is made, then holding the infant in an upright or prone across the lap or on a hot water bottle or heating pad occasionally helps. Sometimes passage of flatus or fecal material, either spontaneously or with the aid of suppository or enema, sometimes offered relief. Carminatives before feeding are ineffective in preventing the attacks. Sometimes, with extremely prolonged attacks and severe attacks, sedations may be required, and temporary hospitalization of the infant, oftenly with no more than change in the feeding routine and period of rest for the parents, may require. Prevention of the attack should be sought by improving the feeding technique, identify a possible allergenic food either in the infant's diet or the nursing mother diet. Usually, it's very important to avoid underfeeding or overfeeding. Although the infantile colic is not serious, it can be particularly disturbing for the parent as well as for the infant. That's why it's very important to be supportive and sympathetic for the parents. It's very important to reassure the parent regarding the benign nature of the condition and to tell them that it rarely persists beyond the 3 months of age. Constipation is practically unknown in a breastfed infant who receive an adequate amount of milk. At the same time, it's rarely seen in a formula-fed infant who's receiving adequate amount of milk. For the diagnosis, we depend mainly on the consistency of the stool, not its frequency. Most infants having one or more stool daily. Occasionally, They have stool of normal consistency at an interval of up to 36 to 48 hours. Whenever constipation or obstipation is present from birth or shortly after that, a PR examination is very important to be done. Sometimes presence of a tight or spastic anal sphincter may be responsible for the obstipation, and during PR examination, a finger dilatation is frequently corrective for the condition. Sometimes presence of anal fissures or cracks may cause constipation, and if irritation is elevated, then healing usually occurs quickly. A ganglionic megacolon may be manifested by constipation in an early infancy. During PR examination, when you found an empty rectum, this may suggest the possibility of this diagnosis. However, further diagnostic workup is usually indicated. Constipation sometimes simply may be resulted from insufficient amount of food or fluid, or it may result from a diet that are too high in protein and or deficient in a bulk. So in these cases, simply increasing the amount of fluid and adding small amount of sugar in the formula sometimes may be corrective during the first few months of life. After this age, a better results are often obtained by adding or increasing the amount of cereal, vegetable, and fruits. A prune juice, about half to 1 ounce, it may be helpful, but adding foods with some bulk is usually more effective. Sometimes, in a severe, unresponsive constipation, giving a small dose of milk of magnesia may be helpful. Enema and suppository should never be used apart from as a temporary measures.